Go.
Hello and good day. My name is Cassandra Sappington. I'm one of the PAs on the Trauma and Acute Care Surgery team. They have asked me to share with you how to manage a chest tube on the floor. So let me introduce you to a couple of the items that we utilize. This is a Pluravac. It's a 3-chambered tool that you'll use. There's the air chamber, the titling chamber, and the collection chamber. The other tools will be the chest tube, which is inserted into the patient at approximately the 4th to 5th intercostal space. Don't ask the provider which one, we don't really know.
And we don't really care.
Left, right, anterior, posterior. That's what's important on your documentation. I'm going to sidetrack to dressing. Can I have 4x4s and some tape? We won't sidetrack to dressing. I don't have the stuff yet. Okay, so what you'll find is this is in the patient. You don't see it. It comes out of the patient. It's dressed. I hate pulling out chest tubes with dressing that smells horrible, is saturated in stuff that you wouldn't want anywhere near your body. So if we want to keep skin intact, the best way to do that is to change your chest tube dressing at least daily and more often if it's saturated. I'll go over a good dressing. It's attached to this. There should be either tape around it to secure it, or if you've been and got it from the OR, it will have little
Zip ties.
Zip ties. This doesn't come apart. This is in the patient all dressed. This is your chest tube drainage system. I need to change this out. I'm going to do a new drainage system. On the back, this is a very easy one. There is a container of saline. You pop the top, you pour it in the blue thing. It's the exact correct amount. Don't use anything else.
Water in the blue hole. Blue for water.
Blue for water. It fills it up to the blue line. This is your air chamber. When a patient breathes, this ball will go up and down. Up and down is called titling. Oh, nice work. That's titling and that's an air leak. It goes below the bottom and you see the air. Suck back. Blow. That's an air leak. It dropped below the line and there's air in this chamber. Now do your sucking for titling. It doesn't go below the line. That is not an air leak. That is the bubbles from this titling so hard. You will see that, but it never dropped below the blue line. If it doesn't go below the blue line, it's not an air leak. Show me an air leak again. There you go, air leak. This will fill up from over here. It will fill all the way across. It has to be documented every 12 hours at how much has come out. We pull the chest tubes depending on quantity of output. You don't document it nice for me, you mess up my day. So to document it, I come in, it's 5 o'clock in the morning because Cassandra's looking at numbers at 5:30 and she prefers to have them there. It's 5 o'clock in the morning, there's this much. I make a line, the date is the 1st, so 4/1 that can clearly be read, and it's 5 o'clock in the morning. I, now rounding at 7 o'clock in the morning, can see what was documented at 5 o'clock in the morning. Now the next day I come to round and the night shift person wasn't as good as the one before, and this is what I have. Now is that today, yesterday, the day before? How long has it been there? It's my first day on. I don't know when we did it last. This doesn't do me any good because there's no date. It's kind of like labeling your blood. Date, time, initials. I'm not making you do your initials, but if you'll give me a date and time, it's really helpful. Dressing. So if you take, this is the foam dressing. It is amazing. When you put it on, you don't put any stretch to it. If you stretch it on the patient, you will give them blisters, but no stretch. And it tears. The problem with it is it does not leak. Why is that a problem, you ask? It's a problem because I can have the most disgusting stuff underneath this tape, and you'll never know about it until I find it when I pull the chest tube. So it's great. It's good to use. Metapore is the other thing that I use, and the reason I use that, it comes off easy. Those are really the only two tapes that I do with this. You do need it to be airtight or you will get a leak from your dressing, or you can get a leak from your dressing. But be aware, if you're using this foam stuff, it won't tell you that you have a bunch of fluid coming out, and it can be really gross.
Don't be afraid to change the dressing. Just be gentle, but don't be afraid to change it and take a look.
The chest tube will be sutured in place, and so not that we can't break the suture and pull the chest tubes, I'm not saying that, but it isn't going to just fall out on your bed. You're just going to be careful. So this is a drainage sponge. What I find is that they don't absorb much, so I don't tend to use them. They do fold better, but they don't absorb better. So I don't tend to use them, but this is a drain sponge. This is just a 4x4. So you have your chest tube and you have the body. You put a folded 4x4 under it. You put a 4x4 over it. You tape it down. Then when you go to take it off, your tape isn't all stuck to your tube all over the place. You can get it off easier. When you put that second one down, just lift up and do a wing underneath it, and then your tube will be secured a little bit better. These are clamps. If you think you need one, call for assistance. If I put a clamp, I have a patient with an active pneumothorax. They're actively leaking air out of their lung into their pleural space. I have an air leak in my chamber. And a person comes up, this tube is doing nothing for the lung that has the leak. The lung has to heal. We are just making it that all the air that comes out of the lung can leave in a nice manner. If I put a clamp on this, what have I now done? I have now closed the chest system, and now I can give my patient a tension pneumothorax, which is a lethal disease. So if you think you need a clamp, call for assistance. If anything about it worries you, these are our babies. We will be happy to come up and help you troubleshoot. If it gets full, you need to switch it. They switch over right here. Disconnect, put it on your new one. You're good. It will fix it. Your patient will not die in the meantime. Any questions? Ask Melissa Platt. She is your educator. Thank you. Oh, Timmons, what would you like to add?
One thing to add. Sometimes this connection here is wrapped up like this with lots of layers around it. So while Cass said this doesn't get connected, what she means is you don't disconnect it, right? You don't ever pull this out, but that doesn't mean that in the course of a patient moving from here to there over the course of several days, that this can't get pulled out like that. So if you have an issue, if something comes up, also don't be afraid to look and see if this has been dislodged. This is a fairly common reason for someone who's never had an air leak to have an air leak. The other common reason for someone who's never had an air leak to develop an air leak is one of these holes is now hanging outside of the body. Thus, don't be afraid to take this dressing down because all those holes will be inside the body. When you take the dressing down, if you take the dressing down and you see holes, you should call a provider. Because that is another very common cause of an air leak, especially in someone who didn't have one before and now all of a sudden they develop one. That's all I have to add. Cass, you did a great job.
Anybody wanting to add that? Thank you so much.